Hi Bacho, I'm Dr. Sakshi Arora Hans, your OBGY faculty at Marrow, and today I am here to discuss with you the INI-CET May 2023 OBGY recall questions. Now, before I take this session any further, how was the paper of INI-CET? Let's discuss a little bit on that. So this time the paper, as I have also seen the recall questions and what you people have also messaged me that you found this paper as moderately tough paper. The questions were such that you could come to two options. You could narrow down your four options to two options, but then you were confused between two options. And you know why does this happen? This happens when you are not thorough with your knowledge. This happens when you are only and only depending upon previous year questions to give any exam. Repeatedly, I have been telling you that previous year questions are important, but then more important are previous year topics. So this time INI-CET was a clear-cut example of a paper where you got questions from those topics, but the repeats were very, very few. Hardly any repeats in this May INI-CET 2023. This kind of an exam you couldn't do well only and only if you are very thorough with your concepts. If your foundation is strong, then only you can do well in such an exam. And this is always what we have strived for here at Marrow. Always we are telling you, please don't mug up answers. Try to figure out why that particular option is correct and why the others are incorrect. Then only you will be able to gain confidence that you can answer any question from that particular topic. Now, when we talk about OBGY, in this INI-CET, there were around 18 to 20 questions which came from OBGY. This time, the questions which came from gynae, they were much more than questions which came from OBS. Usually, it is OBS questions have more weightage in comparison to gynae, but this time it was the other way around. OBS and gynae was a very, very doable paper if you have, the questions were very doable if you have understood your concepts well and if you were not in a hurry to mark the answers. Now, in OBS and gynae, out of those 20 questions, 10 to 12 questions were such which were, direct questions. 5-6 questions were such where you could get stuck between two options. But then, as I told you, with good concepts and a strong foundation, all questions, most of the questions you would be able to answer from OBGY. Now I'm going to take up all the OBGY recall questions with you. And towards the end of the session, I will also discuss with you that how you should prepare for the INI-CET, which is now there on November 5th. So 5th November, you have your next upcoming INI-CET, although I just hope that all of you get through this May INI-CET 2023. But just in case you were not able to get through it, so towards the end of the session, we'll also discuss that what should your strategy be now for the 5th November INI-CET, right? So, coming to the first question, which was asked from the important area, and that particular area is very important in INI-CET, and that is disorders of sexual development, normal sexual development, disorders of sexual development, and primary amenorrhea. This was a very, very straightforward question. SRY gene is located at, so all of you know that SRY gene is located on the short arm of Y chromosome. Right? So, as I have told you here also that SRY gene is also called as the sex determining factor, and this sex determining factor is located on the distal part. So, remember, it is located on the short arm of Y chromosome, but it is located on the distal end of the short arm of Y chromosome. Another very important thing is which micronutrient is needed for SRY gene to function. So, zinc is needed for SRY to function. Third important question for all of you is, where is the androgen receptors located? Where is the gene for androgen located? So, where is the gene for androgen located? It is exactly opposite of where SRY gene is located. Gene for androgens, it is located on the long arm of X chromosome. Right? SRY gene is on short arm of Y chromosome. Androgen gene for androgen synthesis, it is on long arm of X chromosome. Clear? Okay. Then there was a second question which was asked on SRY region, and the question was, in a 46XX female on doing amniocentesis, complete gonadal dysgenesis was noted. Complete gonadal dysgenesis is caused by what in the SRY gene? So please remember, complete gonadal dysgenesis, it could come in complete gonadal dysgenesis could be happening in a 46XX karyotype, or it can be happening in a 46XY karyotype, right? Although it is more common in 46XY karyotype, and when complete gonadal dysgenesis happens in 46XY karyotype, that is what is called as Swyer's syndrome. Now, whether it is happening in 46XY karyotype or whether it is happening in 46XX karyotype, in 85% cases, the reason is idiopathic. We don't know why this happens. That why is the gonad not developing in spite of having a proper karyotype, right? In spite of having two X chromosomes and absence of Y chromosome in a 46XX individual, why is the gonad not developing? Or in spite of having the SRY gene in case of 46XY individual, why is the gonad not developing? So in 85% cases, it is idiopathic. In rest 10 to 15% cases, as I have made you write, in case of 46XY individuals, it happens because of mutation in either SRY gene or mutation in SOX9 gene. And these mutations, most of the times, they are point mutations, right? Although this is not the only mutation, but it is a point mutation. It is an inactivating mutation. So this inactivating mutation, which is in the form of a point mutation, it is going to inactivate the SRY gene in case of 46XY individuals. And same happens in case of 46XX individuals. There is a point mutation in 46XX individuals, which results in complete gonadal dysgenesis, right? So over here, the answer to your question is point mutation, right? Okay. Then coming to the next question, in which of the following statements will you suspect primary amenorrhea? Now, in this case, they have given you 4 options, and this was a multiple correct answer question. So they are saying failure to attain menarche by 15 years of age, option A. Option B, failure to attain menarche even after 3 years of thelarche. Option C, high levels of TSH and short stature. Option D, failure of development of breast by 13 years of age. So in the video on primary amenorrhea, I have told you the conventional definitions for primary amenorrhea, and in the video of secondary amenorrhea, I have told you that Williams 4th edition gynae, they have revised the definitions for primary amenorrhea. So I have also given you the new definitions for primary amenorrhea. According to conventional definition of primary amenorrhea, primary amenorrhea is when there is no menarche by 15 years of age in presence of secondary sexual characteristic, in other words, in presence of breast budding, or by 13 years of age in absence of secondary sexual characteristic. This is the conventional definition which we are following till now. Now, the new edition of Williams, that is Williams 4th edition gynae, it has defined primary amenorrhea as absence of menstruation by 15 years of age. That is one definition which they have given. Second definition is absence of menstruation within 3 years of thelarche. Please remember that usually menarche happens within 2 years of thelarche, right? But if there is a difference of 3 or more than 3 years between thelarche, that is between breast budding and menarche, that is also what is called as primary amenorrhea. And the third definition which I have told you, which has been given in Williams, is if a female has not menstruated by the age of 14 and she is showing you signs of hirsutism or excessive exercise or eating disorder, and this is the latest definition which ACOG gave in 2017. So, in my videos also, I have told you, and in all my offline classes also, I tell you that it is very important for you to remember the new definitions as well as the conventional definitions. So, going by this, the answer to this question is, so option A is correct, that failure to attain menarche by 15 years of age. That is by the new definition also and by conventional definition also. Then failure to attain menarche even after 3 years of thelarche, that is by the new definition. Failure Failure of development of breast by 13 years of age, that is by the failure of development of breast by 13 years, and obviously no menarche by 13 years. Again, this is by the old or the conventional definition. So the answer over here should be A, B and D. The option, that is option C, which is saying A, B and D are the correct statements. As far as secondary amenorrhea is concerned, secondary amenorrhea is absence of menstruation for 90 days or for 3 months. This is the best definition in a female who was previously menstruating normally. If there is absence of menstruation for 90 days or 3 months, that is what is called as secondary amenorrhea. This is by the conventional definition also, and this is by the new definition also. Now, remember that if a female is having less than 9 cycles in a year, this is what is called as, was earlier called as oligomenorrhea, and this should also be investigated. So, whenever a female is having less than 9 cycles in a year, that calls for investigations related to secondary amenorrhea, right? Okay. Then the next question was a very interesting question which you could solve based on what I had taught you and based on your concepts. So the question says a 15-year-old female presents with primary amenorrhea and signs of virilization. So there is primary amenorrhea and there are signs of virilization. Plus signs of virilization are present. Right? Then she has pre-pubertal development of breast and pubic hair, that is Tanner stage 2. So breast and pubic hair both are belonging to Tanner stage 2. Okay. She has a blind-ended vagina. So blind-ended vagina, which means there is no other internal genital organ, only she is having a blind-ended vagina. And in her external genitalia, clitoromegaly was noted, right? Then she has normal male testosterone levels. That is also very important. Her testosterone levels are normal male testosterone levels. And they are saying she is a 46XY karyotype individual. Right? Now you have to tell what is the probable diagnosis. Now, in all the options which they have given you, as you note over here, complete androgen insensitivity is also 46XY, Swyer syndrome is also 46XY, and then steroid 5-alpha reductase deficiency, that is a hormone, that is an enzyme deficiency, which is also seen in 46XY individuals, and 17-alpha hydroxylase deficiency, that is also an enzyme deficiency, which leads to a disorder sexual development in XY individuals. So all these are related to XY karyotype, right? Now, let us see what happens in complete androgen insensitivity syndrome. All of you know that in complete androgen insensitivity syndrome, the problem is that they are insensitive to androgens. Because they are insensitive to androgens, that is why Wolffian duct is not going to grow in them. And because Wolffian duct is not going to grow, so they will not have any internal genitalia. Remember that in these individuals, Sertoli cells are functioning normally, so they are releasing anti-Mullerian hormone normally, and that is why even female internal genital organs are absent. So they don't have any male internal genital organ because Wolffian duct also regresses, and because Sertoli cells are forming anti-Mullerian hormone, so Mullerian duct is also regressing. So no male or no female internal genital organs. Yes, they may have a blind-ended vagina, right? So yes, a small blind vagina is going in favor of complete androgen insensitivity syndrome. Now, these individuals, when you look at their external genitalia, because testosterone and dihydrotestosterone, both of them, they act through the same receptors. That is why if an individual is completely insensitive to testosterone, they will also be completely insensitive to dihydrotestosterone, and that is why in them there will be exactly female looking external genitalia. Clitoromegaly means ambiguous genitalia. In these individuals, there is no ambiguous genitalia. Exactly female looking external genitalia, right? So that is again going something which is not going in their favor because the question is talking about clitoromegaly, okay? Then in these individuals, when they are going, so at birth they are taken as a female, and when they are going to grow up at puberty, again they are insensitive to testosterone. Because they are insensitive to testosterone, so male secondary sexual characteristics will not develop. In other words, there will be no virilization. Again, a point which is going against them. The question was saying that virilization was present, and because virilization, just in case if virilization would have been present, then clitoromegaly would have been present. But in these individuals, because they are insensitive to testosterone, so there are no signs of virilization. And because they are insensitive to testosterone, so yes, pubic hair will correspond to Tanner stage 1 or 2. But then this entire testosterone is going to get converted into estrogen, and it is going to lead to breast development. So incomplete androgen insensitivity syndrome, breast development corresponds to Tanner stage 4 or 5. Again, a point which is going against them. So I can't make the diagnosis of complete androgen insensitivity syndrome. Yes, the testosterone levels in them are male testosterone levels, but because the question is saying breast development corresponding to stage 1 or 2, that is against complete androgen insensitivity syndrome. Question is saying clitoromegaly, which is again against complete androgen insensitivity syndrome. Question is saying signs of virilization are present, which is again against complete androgen insensitivity syndrome. So the diagnosis is not complete androgen insensitivity syndrome. Now, the other option which was given to you was Swyer syndrome. Swyer syndrome, what is the problem? In Swyer syndrome, like I was telling you just now, that there is going to be an inactivating mutation. So the SRY gene gets inactivated, and that is why they have dysgenetic testes. Right now, because they have dysgenetic testes, the testes will not, the Sertoli cells will not form anti-Mullerian hormone, and because Sertoli cells will not form anti-Mullerian hormone, so Mullerian duct will grow, and they will have proper female internal genital organs. Right, so in them fallopian tube will be present, uterus will be present, cervix will be present, vagina will be present. So the question will never say that they had a short blind ending vagina. Question is going to say uterus was present, cervix was present, vagina was present. So this point is going against Swier's syndrome. Now, because in them, even the Leydig cells will be dysgenetic, so Leydig cells will not produce testosterone. Because Leydig cells will not produce testosterone, so the levels of testosterone will be low in them. Are you understanding? So your question can never say that testosterone levels are normal male levels. No, in Swyer syndrome, the testosterone levels are decreased. And because testosterone levels are decreased, their external genitalia are female external genitalia. Again, clitoromegaly is not present in them. Are you understanding this? Now, again, this child will be taken as a female child at birth, and when the child is going to grow up, at puberty, the child will not have any testosterone. So, at puberty, the testes will remain dysgenetic. They will not produce any testosterone, so there will be no virilization in them. And because there will be no virilization, again, it is going against what the question has given. Question has given that signs of virilization are present. Now, because the testosterone levels are decreased, that is why pubic hair and axillary hair will correspond to Tanner stage 1 or 2, and breast development will not happen because there is no testosterone, so it will not get converted into estrogen. Are you understanding this? So your diagnosis cannot be Swyer syndrome. Now, what happens in 5-alpha reductase deficiency? Now, first let me show you. I have taught you 5-alpha reductase deficiency in your videos, in my classes, and in detail we have discussed 5-alpha reductase deficiency. Now, let me see how many of you can remember what I taught you. 5-alpha reductase is an enzyme which is needed for conversion of testosterone to dihydrotestosterone. So, problem is that there is deficiency of this enzyme, which means that now testosterone will not get converted into dihydrotestosterone. Rest everything is normal. The testes are normal, Sertoli cells are normal, Leydig cells are normal. Now, because Sertoli cells are normal, that is why anti-Mullerian hormone will be absent and there won't be female internal genital organs. Now, because testosterone is normal, so Wolffian duct is going to grow, and that is why they will have male internal genital organs. But yes, they may have a blind ending vagina. Right? That is just one thing which they may have. Right? Now, suppose even if you didn't remember this point, now let us go ahead and see what is going to happen in them. Now in intrauterine life, because testosterone is absent, so their external genitalia will be female external genitalia at birth. So you're going to say, ma'am, this is not in a sync with what the question had given. Hold on just now. I am saying at birth they have exactly female looking external genitalia, right? And they are taken as a female child at birth. Now, once this child grows up and it reaches the age of puberty, what is going to happen when the child reaches the age of puberty? At the age of puberty, because the testes will keep on secreting testosterone. And what will this testosterone do? This testosterone will bring about signs of virilization. So this child who was taken as a female child will start showing some male secondary sexual characteristics. For example, now at puberty, there is going to be clitoromegaly, and this is exactly what I have told you, that these children are taken as female child at birth. At puberty, testosterone is present. It leads to secondary sexual characteristics of males, deepening of voice, increased muscle mass, increased libido. At puberty, some virilization of the female external genitalia is there, which was not at birth, and this leads to clitoromegaly. And this child has come to you at the age of puberty. So at the age of puberty, yes, I am going to get clitoromegaly in children with 5-alpha reductase deficiency. Are you getting this point? At birth, there won't be any clitoromegaly, but at puberty, because they have testosterone, and that testosterone corresponds to a normal male testosterone, which is going to lead to virilization signs at the time of puberty and also to clitoromegaly. Right? And as far as pubic hair is concerned, and as far as breast development is concerned, now in these individuals, the breast development is not going to happen again, because testosterone will not get converted into estrogen. As far as pubic hair is concerned, again pubic hair are scanty in them. That is because they don't have dihydrotestosterone. Because they don't have dihydrotestosterone, so it is not just testosterone which is needed for development of pubic and axillary hair. It is dihydrotestosterone also which is needed for pubic and axillary hair development. Normally we say that androgens are needed, right? We don't specify which androgen, but in this case I have specifically told you that dihydrotestosterone is also needed for pubic hair and axillary hair. It is also needed for body hair. So in these individuals, there is going to be less body hair, there is going to be less pubic hair, less acne, less temporal hairline recession. All this is happening because of no dihydrotestosterone. Right? So the answer to the question is 5-alpha reductase deficiency. Now, why not 17-alpha hydroxylase deficiency? For understanding that, I want you to first look at this adrenal gland physiology. Where is the 17-alpha hydroxylase enzyme needed? 17-alpha hydroxylase enzyme is needed for the formation of DHEA, for the formation of androstenedione, and because androstenedione gets converted into testosterone, so for the formation of testosterone. Right? Now, if 17-alpha hydroxylase enzyme is less, so DHEA is going to be less. Yes, androstenedione is going to be less and testosterone is going to be less, as you can see from this adrenal gland physiology here. So, what are the hormones which will be less? DHEA will be less, androstenedione will be less, and testosterone will be less. Now, because testosterone, DHEA and androstenedione are less, that is why in XY karyotype, it is going to lead to a disordered sexual development. It is not going to affect the external genitalia of a female. Why? Because female external genitalia develop in absence of any hormone stimulation. The natural tendency of external genitalia in a fetus is to develop into a female external genitalia. Only if testosterone and dihydrotestosterone are present in adequate volume, right, then it leads to formation of male external genitalia. If testosterone and dihydrotestosterone are less, right, then it leads to formation of ambiguous genitalia. Are you understanding this? So in this case, what is going to happen? In this case, this child is going to have ambiguous genitalia, right? So this child can have ambiguous genitalia depending upon testosterone and dihydrotestosterone levels, right? So depending upon what are the levels of testosterone or dihydrotestosterone, the individual can have female looking genitalia or the individual can have ambiguous genitalia, and they are going to have a short blind vagina. Are you understanding this? This is because adrenal androgen production is decreased. The testes will still produce the testosterone in males, in XY individuals, and in this XY individual also the testes will produce testosterone. But how much testosterone the testes are producing, how much is adrenal producing, all that adds up to the male external genitalia looking like a male external genitalia, right? So if the testosterone levels and dihydrotestosterone levels are very less, it leads to female external genitalia. If the levels are less but not very less, it leads to ambiguous genitalia. So this individual can have either ambiguous genitalia or they can have female external genitalia, and they are going to have a short blind vagina, right? Now also see over here that when this enzyme 17 alpha hydroxylase enzyme will be deficient, 17 hydroxy pregnanolone levels will be less and 17 hydroxy progesterone levels will be less, right? And when 17 hydroxy progesterone levels will be less, cortisol levels will be less, and cortisol has a negative feedback on ACTH. So when cortisol levels will decrease, the negative feedback on ACTH will be lost, and so ACTH levels will increase. Now, for the formation of aldosterone, 17 alpha hydroxylase enzyme is not needed. So, what is going to happen when ACTH levels are going to increase? All this is going to increase. Now, pregnanolone will increase. It will get converted into progesterone, deoxycortisone, cortisone and aldosterone. So, finally, these children are going to have increased aldosterone. They are going to have increased aldosterone, and all the sex hormones, the androgens, the androstenediones and the testosterones and DHEA will be decreased. Along with that, 17 hydroxyprogesterone levels are also decreased. Right? Is that clear to all of you? So now, because there is increased aldosterone, when these children will be born, now whether that child is 46XX or 46XY, in both of them there will be increased aldosterone. Right? So when these children will be born, they are going to have hypertension due to hypernatremia and hypervolemia, and they may also have hypokalemia. This is something which we have to keep in mind. So in a 46XX child who will be born with 17 alpha hydroxylase deficiency, we have to take care only of this thing, that there is going to be hypertension, hypernatremia, hypervolemia and hypokalemia. In a 46XY individual, there is going to be either ambiguous genitalia or exactly female looking genitalia with a short blind vagina, and along with that they are going to have hypertension. Clear to all of you? Yes. So in this question, the answer was 5 alpha reductase deficiency. Why it was not 17 alpha hydroxylase deficiency? Just now I told you. In 17 alpha hydroxylase deficiency, the levels of testosterone will be decreased. They will never be normal male levels, right? And if the levels of testosterone are decreased, obviously the child cannot show you signs of virilization. So the signs of virilization will also not be present when the child is going to grow up at puberty, right? So these two things go against 17 alpha hydroxylase deficiency. Clear? Okay. Now that was a very good and a concept based question. So they may have a short blind vagina. That is something which they are going to have, right? Now also understand that this is the problem which is happening because DHEA is decreased, testosterone is decreased and androstenedione is decreased. Now, because what is going to happen is that when this 17 alpha hydroxylase enzyme will be deficient. Now 17 alpha hydroxylase enzyme is also needed for production of 17 hydroxypregnanolone, which is needed for production of 17 hydroxyprogesterone, which in itself is needed for formation of cortisol. So if 17 alpha hydroxylase enzyme is deficient, even cortisol levels are going to decrease. And this is cortisol, which has got a negative feedback on ACTH. Normally, cortisol keeps ACTH under control. When the levels of cortisol will be decreased, the levels of ACTH in this child is going to increase. Now, when the levels of ACTH will increase, what is going to happen? This arm over here, this doesn't require 17-alpha hydroxylase enzyme. So when ACTH will increase, pregnenolone will increase, progesterone will increase, deoxycortisone will increase, cortisone will increase, and aldosterone will increase. Now, this is what I'm now going to tell you, that aldosterone levels are increased in any child who has 17-alpha hydroxylase deficiency, whether their karyotype is 46XX or 46XY. Right? So when a child of 17-alpha hydroxylase deficiency is born, both XX and XY karyotype, such children are going to have hypertension. They are going to have hypernatremia. They are going to have hypervolemia, and some may also have hypokalemia. Right? This is going to be seen in both XX and XY individuals. In XY individuals, the external genitalia will either look exactly like female external genitalia, or it may be ambiguous genitalia. Most of these children who have 17-alpha hydroxylase deficiency and they are 46XY. So most of the children with 46XY with 17-alpha hydroxylase deficiency, they are taken as a female child at birth. Now, when this female child is going to grow up, what is going to happen? At puberty, again, they will have decreased testosterone, right? Because of the deficiency of 17-alpha hydroxylase enzyme. So, if they have decreased testosterone, they are not going to have any signs of virilization. And both these things go against our question. Our question was saying that the levels of testosterone are normal male levels. It cannot happen in this case. Our question was saying signs of virilization present. That is also not happening in this case. Right? Now, because they don't have any testosterone, the levels of testosterone are decreased. So, they have scanty pubic hair and the testosterone will not get converted into estrogen. So, no breast development. Right? And these individuals, they are going to come to you as a female child with primary amenorrhea, or she is going to come to you with complaint of delayed puberty. When you are going to do lab investigations in them, you are going to see that the testosterone levels are decreased. Normally in congenital adrenal hyperplasia, 17-hydroxyprogesterone levels are increased. In this case, 17-hydroxyprogesterone levels are decreased. Aldosterone levels are increased. Right? So, I hope you've understood this question now, that the answer to this question over here is 5-alpha reductase deficiency. This was a very, very interesting and a concept based questions. If your concepts are clear, you could have answered this question very well. Right? So, in brief, what are those enzyme deficiencies which affect XX individuals? So, XX individuals, the most common enzyme deficiency is 21-alpha hydroxylase deficiency, second most common being 11-beta hydroxylase deficiency. What are those enzyme deficiencies which affect XY individuals? It is 17-alpha hydroxylase deficiency or 17-20 lyase deficiency. You have to remember that enzymes which begin with the number 17, they affect the XY individuals and not XX individuals. What are those enzyme deficiencies which can cause ambiguous genitalia in both XX and XY? And they are 3-beta HSD deficiency or P450OR deficiency. P450OR means P450 oxidoreductase enzyme deficiency. Right? So, these are two enzymes which can lead to ambiguous genitalia in both XX and XY individuals. Congenital adrenal hyperplasia, disorders of sexual development, they are very, very important for INI-CET exams. So, next time also, before you appear for your INI-CET, this is one topic which you definitely have to revise. Right? Coming to the next question, which was a related question to primary amenorrhea, and this is, which of the following is not essential in the workup of a Turner mosaic? So, all of you know that in Turner's syndrome, the karyotype is 45XO, right? But mosaic, what is a mosaic? Mosaic means that the karyotype is 45XO 46XY. These individuals are called as mosaics, and that is why in Turner's syndrome it is very important for us to do a karyotype even if a clinical diagnosis of Turner's has been made, because these are the individuals in whom Y chromosome is present, and that is why there are increased chances of malignancy in their streak gonads as well. Right, so in them the gonads will have increased chances of malignancy. Which malignancy? Gonadoblastoma. And that is why in all Turner syndrome babies you have to get a karyotyping done. Now we all know that in Turner's syndrome they have streak gonads, and because they have streak gonads, the levels of estrogen are decreased. What is their internal genitalia? Internal genitalia are normal female internal genitalia, but because estrogen is needed for growth of uterus, right, in a non-pregnant state, that is why in all these individuals uterus will be hypoplastic, right? So they will have a hypoplastic or infantile uterus. External genitalia will be female external genitalia. Now because estrogen is absent, estrogen is the one which is needed for breast development, so breast will be decreased. So there will be absent secondary sexual characteristic. Breast will correspond to Tanner stage 1 or 2. As far as stature is concerned, they have short stature, and they come to you as a case of primary amenorrhea with absent secondary sexual characteristics. When you do their lab investigations, levels of LH and FSH are high and levels of estrogen are decreased. Because estrogen is decreased, the negative feedback on LH FSH is lost, so the levels of LH and FSH is high. This is very, very important because these days they are asking you questions based on hormonal assays also. So anytime you get a female with primary amenorrhea with absent secondary sexual characteristics and estrogen decreased, LH FSH increased, it has to be either Turner syndrome or it has to be a case of Swyer's syndrome. Right, so either of these two, in these two the levels of LH and FSH are increased and the levels of estrogen are decreased. That is hypergonadotropic hypogonadism. Now, why I'm telling you Turner's syndrome is because in Turner's syndrome, there are certain additional characteristics along with this. What are the additional characteristics? You get webbing of neck, you get low posterior hairline, shield-shaped chest, widely spaced nipples. And these Turner syndrome babies, as I have taught you in your videos, they are associated with many complications, like they have congenital heart disease, which is present in 1/3 of the patients, and the most common congenital heart disease present in them is bicuspid aortic valve followed by coarctation of aorta. This means that whether it is a Turner mosaic or whether it is a Turner syndrome, number one, I have to do a karyotyping in them. Number two, because they have increased chances of cardiac diseases, I am going to go for echocardiography in them. Right, then they have increased chances of autoimmune diseases, and autoimmune diseases I told you are diabetes mellitus and Hashimoto's thyroiditis. Now all the marrow subscribers, the non-marrow subscribers also, you should also know what are the autoimmune diseases. But why I'm saying this to marrow subscribers is I want these things to be added in your notes, that the autoimmune diseases which are seen in Turner's syndrome are diabetes and Hashimoto's thyroiditis, but along with that autoimmune hepatitis, thrombocytopenia and celiac disease. So this means that when they have increased chances of diabetes mellitus, I am going to do a GTT in them. They have increased chances of thyroiditis, so I am going to check their TSH levels. They have increased chances of autoimmune thrombocytopenia, so I am going to do a CBC in them. They have increased chances of autoimmune hepatitis, so I am going to do LFT in them. I am going to do a KFT also in them. Right, and because they have increased chances of celiac disease, I am going to do anti-endomysial antibodies to detect the celiac diseases. Right. Apart from this, in Turner's syndrome, hearing loss is common. Please add this to your notes, that hearing loss is common, and the most common hearing loss which you get is sensory neural hearing loss. And they also have increased chances of renal anomalies like horseshoe-shaped kidney or unilateral renal agenesis. Now, this means that if they have increased chances of hearing loss, and the most common hearing loss which is seen in them is sensory neural hearing loss, so I have to do audiometry in them. And because they have increased chances of renal anomalies, I am going to do an intravenous pyelography in them. So the set of investigations which you have to do in all patients who have come to you as a Turner syndrome, in order to make a diagnosis as well as to treat, to know what all complications they have, are number one, karyotyping. Number 2, echocardiography. Number 3, renal ultrasound. Number 4, TSH and free T4 levels. Number 5, a complete blood count, then fasting glucose levels, lipid profile, renal function test and liver function test, and then anti-endomysial antibodies to detect celiac disease and audiometry. This is a screenshot which I have included from Leon Spiroff, and this is very, very important for all of you now. Right? So over here in the options you were given, which of the following is not essential? So glucose tolerance test, it is essential. Audiometry, it is essential. Echocardiography is essential. It is not anti-nuclear antibodies. It is anti-endomysial antibodies which you have to test in a patient of Turner's syndrome. Clear to all of you? Yes? Okay. Then coming to the other thing which I want to tell you, because Turner syndrome has been asked in your INI-CET, this becomes a very important topic for you now. Remember that in all Turner syndrome babies, the intelligence is normal. Turner syndrome females may have attention deficit syndrome or hyperactivity. Such females may have attention deficit disorder or hyperactivity disorder. And overall, the risk of cancers is same, but there are certain cancers which are more in these females rather than the general population. These are CNS tumors, bladder cancer, and for some reasons, endometrial cancer. And what is that reason? That reason is that in all these females, for breast development, we give them initially estrogen alone, and that may result in an increased chances of endometrial cancer. So bladder cancer, CNS cancers and endometrial cancers, their incidence is slightly increased, but overall the cancer incidence is normal like it is seen in general population. Right? Intelligence is normal, but they may have attention deficit hyperactivity disorder, that is ADHD. Right? Okay. Next question, all of the following can result in a non-immune hydrops fetalis except. Again, this was a very, very straightforward question. You all know that immune hydrops fetalis means that mother is forming antibodies against some fetal antigen, and that is leading to fetal hemolysis. Right? And this can happen only if there is either RH incompatibility or ABO incompatibility. Right? So, immune hydrops fetalis is seen in RH negative pregnancy, and it is also seen in ABO incompatibility. So, ABO incompatibility or RH incompatibility. Other than that, if for any other reason a baby is having hydrops fetalis, fetus is having hydrops fetalis, it means it is a non-immune cause. Now, the common non-immune causes, the most common cause is cardiovascular diseases. Right? That is number 1. Number 2, the second most common causes if the fetus has alpha thalassemia. Then it could also be due to chromosomal anomalies. In chromosomal anomalies, the most common is aneuploidy, and in aneuploidy, most common is monosomy X. Right? Then certain maternal infections like parvovirus B19 infections, torch19 infections can also lead to non-immune hydrops fetalis, and inborn errors of metabolism can also lead to non-immune hydrops fetalis. I want you to remember that non-immune hydrops fetalis ka most common cause cardiovascular anomaly. Second most common cause alpha thalassemia. In chromosomal disorders, which is the most common cause, aneuploidy. In aneuploidy, which is the most common one, monosomy X. Also, I want you to remember that what is the most common cause of hydrops fetalis seen in second trimester. Most common cause of hydrops fetalis which is diagnosed or seen in second trimester is Turner's syndrome. Then please remember that hydrops fetalis is a diagnosis which is made only on ultrasound, and on ultrasound if 2 or more than 2 of the following 3 are present, then we say that the fetus has hydrops fetalis. What are those 3 out of which 2 have to be present? Pericardial effusion, pleural effusion, ascites. So any of these 2 if they are present, that means there is hydrops fetalis. Or suppose if the fetus has anasarca, along with anasarca, if any one of these is present, then it is called as hydrops fetalis. Now remember that scalp edema, polyhydramnios and placentomegaly, they are features of hydrops fetalis, but they are not included in the diagnostic criteria. So in diagnostic criteria, earlier scalp edema was being included, but now scalp edema is also not included in the diagnostic criteria. So placentomegaly, polyhydramnios and scalp edema are not included in the diagnostic criteria. Diagnostic criteria for Hydrops fetalis is if two of the following three are present, which is pericardial effusion, pleural effusion and ascites, right? Or generalized anasarca along with any one of them. Clear? Okay. So the answer to this question over here is ABO, incompatibility. All of the following can result in non-immune Hydrops fetalis. So chromosomal defect can result in Hydrops fetalis. It can lead to Hydrops fetalis. Parvovirus can lead to Hydrops fetalis. Alpha thalassemia can lead to Hydrops fetalis. ABO incompatibility leads to Hydrops fetalis, but it leads to immune Hydrops fetalis and not non-immune Hydrops fetalis. Right? Okay. Then there was a question which was there. A 38-year-old multigravida presents with 2 years of infertility, dyspareunia and dysmenorrhea. So patient has come to you with complaints of infertility, dysmenorrhea and dyspareunia. She has a retroverted uterus and tenderness in pouch of Douglas. What would be the next step in management? So this is exactly from your notes. I have told you that in endometriosis, patients' ki most common complaint is pain, and that pain is in the form of secondary dysmenorrhea, or it could be in the form of dyspareunia. Mostly it is secondary dysmenorrhea, but dyspareunia can also be there. Then the second most common complaint with which the patient comes to you is infertility, and the third most common complaint is adnexal mass. And I told you that out of these four things, dysmenorrhea, dyspareunia, infertility, adnexal mass, they are going to make a triad of any three symptoms, and they are going to ask you to make a diagnosis. And that is exactly how the question has come. They have given you secondary dysmenorrhea, they have given you dyspareunia, and they have given you infertility. So you know that the diagnosis is endometriosis. Now, if still there was a confusion, then I also told you that on per vaginal examination, in case of endometriosis, uterus is not enlarged, it is not tender, it is fixed retroverted uterus. This term fixed retroverted uterus is typically used to define the per vaginal findings in endometriosis. Retroverted uterus can be seen in prolapse also, but what is the difference? In prolapse, when you get a retroverted uterus, it can be manually corrected. But in case of endometriosis, when you get a retroverted uterus, it cannot be manually corrected, and that is why it is called as a fixed retroverted uterus. Whenever you get this pervaginal finding, immediately you should be able to make a diagnosis of endometriosis. Another thing which I told you, in endometriosis, uterus is not tender, because if uterus is tender, it means they are talking about adenomyosis, right? In adenomyosis, uterus is 12 to 14 weeks enlarged uterus and it is tender. In endometriosis, uterus is not enlarged, it is not tender, it is fixed and retroverted. In endometriosis, when you are going to check the adnexa may tenderness will be present, and because of the chocolate cyst, an adnexal mass can be palpated. In case of adenomyosis, in adnexa you don't get any tenderness, you don't get any adnexal mass. So I have made you write that. Adnexal mass will be present, tenderness in pouch of Douglas, tenderness in the adnexa, right? And that is how exactly the question is saying, that she has a retroverted uterus, tenderness in pouch of Douglas, right? And that is why I keep on repeating, bacho, the notes which I give you, each and every line is very, very important for you, right? Then they have asked what is the next step, and exactly this is what I have also told you, that whenever a female comes with you with complaint of dysmenorrhea, or if she is coming to you with pain, or if she is coming to you with adnexal mass, or if she is coming to you with AUB, I have included AUB over here so that you remember that if these are the primary complaints of the patient, if patient has come to you with dysmenorrhea, if patient has come to you with adnexal mass or with AUB, and they ask you what is the first investigation or what is the next step, always next step is TVS. Now you tell me, as a clinician, you know that endometriosis may investigation of choice is laparoscopy. But answer over here is not going to be laparoscopy, because they have asked you what would be the next step in management. You tell me that a patient has come to you, you are sitting at an OPD and a patient has come to you with dysmenorrhea, right? Dyspareunia. and you tell her that I am going to do a laparoscopy tomorrow because you are having dysmenorrhea and dyspareunia, will that patient ever come back to you? No. So laparoscopy is never the first investigation to be done in cases of dysmenorrhea, dyspareunia, right? Laparoscopy you will do, but at a later stage. First, you are going to do a TVS. On TVS, in case of endometriosis, you may be able to see a chocolate cyst. And I have also told you what is the typical word which they are going to use when they are going to describe a chocolate cyst. In a chocolate cyst, you get homogeneous internal echos. A cyst with homogeneous internal echos. This is the typical finding which you get in case of chocolate cyst. Ground glass appearance or homogeneous internal echos, right? But then, beware, absence of a chocolate cyst does not mean endometriosis is absent. You may get a chocolate cyst on ultrasound, that's good. But then if chocolate cyst is not seen, or if the chocolate cyst is not there on ultrasound, that doesn't mean that your patient doesn't have endometriosis, right? So at what stage do you do laparoscopy in endometriosis? All the Marrow subscribers, you know this. I have clearly told you that you are not going to do laparoscopy immediately. Even if ultrasound findings are coming as normal, my aim for getting ultrasound was, number one, to see whether a chocolate cyst is present or not, and number two, to rule out other problems, because dysmenorrhea can happen due to fibroid as well, right? So to rule out other problems, I did a TVS. But when am I going to do laparoscopy in a patient of endometriosis? So if even the ultrasound findings are coming as normal, I will put her on treatment. You know, if she's come to me with a complaint of dysmenorrhea, I'm going to treat her for dysmenorrhea first. I'm going to do a medical management, and if my medical management fails, then I am going to go for laparoscopy, not immediately. The last important thing which I want to point out to you is this word dyspareunia. The moment you read this word dyspareunia along with dysmenorrhea, it should again tell you that they are talking about endometriosis. In a fibroid, dysmenorrhea will be present, but dyspareunia will never be present. Right? In a polyp, you will never get dyspareunia. In adenomyosis, you may get dyspareunia, but that is rare. In adenomyosis, mostly patients come to you with complaint of excessive bleeding, that is menorrhagia and dysmenorrhea. So this word dysmenorrhea and dyspareunia, the moment you read this, it means they are talking about endometriosis, and the first investigation or the next step in management is ultrasound. Investigation of choice is laparoscopy. Gold standard investigation is histopathological examination. Coming to the next question, which is again related to dysmenorrhea. Which of the following statements about primary dysmenorrhea is true, right? So you remember primary dysmenorrhea, it is not due to any pelvic pathology, it is due to the prostaglandin which is released because of the progesterone withdrawal, right? So pain begins 3 days prior to the onset of period and is present up to 2 days, second day of the period. B, pain begins after few hours after the onset of period and can last up to 48 hours. Option C, it is dependent on psychological factors. Option D, GnRH antagonist are the first line of treatment. Now, before I start commenting on this, I will show you first what is written in Leon Spirov, which is the Bible of gynecology. Right, on page 495, it is written, classically in primary dysmenorrhea, pain begins just before or coincident with the onset of menses. So, pain is going to begin just before or along with menses, and it declines gradually over the subsequent 72 hours, right? This pain may vary in intensity and it is centered in the suprapubic region, right? So when is the pain going to begin? Just before or along with the onset of menstruation, and it is going to be there maximum for 72 hours. Now, this is what even I have made you, right? I have made you make a table of differences between primary dysmenorrhea and secondary dysmenorrhea. Primary dysmenorrhea begins with menses or just before menses. Secondary dysmenorrhea occurs much before the onset of menses. Primary dysmenorrhea gradually decreases within 72 hours. It never lasts more than 72 hours. Secondary dysmenorrhea remains even after the onset of period, and it is going to last for more than 72 hours. Primary is spasmodic in nature. Secondary is congestive. Primary is is intermittent and has varied intensity. In case of secondary dysmenorrhea, the pain is going to be progressive. There is going to be progressive dysmenorrhea. Patient is going to say that gradually, as the time is passing, the intensity of a pain is increasing. Then primary dysmenorrhea is centralized. It is generally seen in the suprapubic region, whereas secondary dysmenorrhea is due to some pelvic pathology, right? So it is going to be localized. Primary dysmenorrhea may be associated with psychological factors, right? Secondary dysmenorrhea may be associated with dyspareunia or dyschasias. So this is exactly what I have made you write, and it is appearing as if the questions have been taken from here. So now you are going to tell me. Option A, pain begins 3 days prior to the onset of periods and is present up to second day. That's wrong. It will never be present 3 days before the onset of periods. Pain begins after a few hours of the onset of period. No, it is going to begin just before the periods or along with the periods, right? It is dependent on psychological factors, definitely. GnRH antagonists are the first line of treatment. No, I told you NSAIDs are the first line of treatment, or you can give OCPs. Why OCPs? Because they're going to make the cycle anovulatory, and anovulatory cycles are painless, right? So the answer to this question is it is dependent on psychological factors. And I have shown you exactly the page of Leon-Spirov where it is given. In Leon-Spirov, they have also given this image, where they have given primary dysmenorrhea and secondary dysmenorrhea. Primary dysmenorrhea ka timing, just concentrate here, with the onset of menses, right? Secondary dysmenorrhea is few days before the onset of menses, right? Okay, so the next question is an interesting question. A 23-year-old female with 6 years of infertility whose BMI is 33, that means your patient is obese. She has facial hair, okay? Investigation reveals she is PCOS and spill from bilateral tubes is there. She and her husband are trying to conceive. What will be the best plan of management for this lady? Now, first of all, whenever a couple come to you for infertility, there are 3 basic investigations which have to be done. What are those 3 basic investigations? Quickly tell me. I've told you them in the videos also. So, number 1 is you have to do the test for anovulation, right? Number 2, you have to do HSG, and number 3 is semen analysis. These are the 3 basic investigations which have to be done in all cases who are coming to you with infertility. Now, in this case, the test of anovulation would have revealed that she is not ovulating, and because she is not ovulating, she has facial hair. So, 2 of the Rotterdam criteria are getting fulfilled. So, she is diagnosed as a case of PCOS. They are saying that the spill is normal in HSG, and we are taking it, since the question has not mentioned any abnormality in semen analysis, we are taking that the semen analysis of the husband is normal. Now, one very important thing you have to remember, which I have taught you in all my videos, is that the first line management whenever a PCOS patient comes to you, especially if she is obese, her BMI is 33, is lifestyle modification and weight loss. Even a 5% weight loss can lead to ovulatory cycles in 5 to 10% cases. Right? So, whenever you have an overweight or an obese PCOS female, in the screenshot I am showing you, I have told you the first thing which you have to do is you have to tell them that they have to undergo weight loss. Now, because she is trying to conceive, definitely I am going to tell her to be on folic acid, and initially, because with weight loss, ovulatory cycles happen in 5 to 10% cases. So, first I am going to tell her to try for spontaneous induction, and if induction fails, then, if spontaneous ovulation, and if spontaneous ovulation fails, then I am going to go for induction. Are you understanding this? This is what exactly I have told you, that initially you have to advise weight loss, especially if your question says she's overweight or obese PCOS patient, because 5% weight loss can bring about ovulation in 5 to 10% cases, right? So, in this case, this is the best answer, that you are going to tell her to advise her to have weight loss, then give her folic acid and tell her that first try for natural conception, and if natural conception is not happening, then I am going to go for induction of ovulation. Now, let us see the other options and see why not the other options. Option A is weight loss plus metformin plus induction of ovulation with clomiphene. Now, please understand, which I have also told you in the lectures, that metformin is the only indication for using metformin is insulin resistance. right? Metformin is not used for weight loss. It should not be used because a female wants to prevent herself from diabetes. For all these indications, you are not to protect herself from having abortions or diabetes in pregnancy. For these indications, metformin should not be used. Only indication for metformin in a PCOS patient is that if patient has insulin resistance, then in a PCOS patient, I'm going to use metformin. Right? Everything about metformin I have made you write over here in your notes, that please do not say that with clomiphene I have to use a metformin. No, you don't. Unless and until your question says that there is insulin resistance. Till that time, you are not going to use metformin. Second thing which I told you was that uh, the best drug for ovulation induction in PCOS patients is letrozole. Right? So, since letrozole was not given in any of the options, so again, letrozole is out of question. But then option A is also incorrect, not because clomiphene was given, right? But because metformin was given. Right? So, I wouldn't have taken option A as the correct answer. Then comes weight loss plus metformin plus induction of ovulation with urinary gonadotropins. I have told you very, very specifically that the drug of choice are the first line drugs for PCOS, drug of choice being letrozole, then the second drug of choice being clomiphene. If they fail, then you go to gonadotropins, that is HMG, and if HMG also fails, then you go to the third line, that is pulsatile GnRH. Right? So, options B is incorrect. Then comes option C, metformin plus finasteride. Now, if you go back to your notes, you will see I have made you write specifically that if patient is on anti-androgens, she should not conceive. This is because if she is carrying a male fetus and if you give anti-androgen, it is going to result in ambiguous external genitalia. Rather, when you are giving an anti-androgen like finasteride, spironolactone, specifically you have to tell a patient that she should not conceive while she is on these drugs. Finasteride, spironolactone, they are all drugs which are used in management of hirsutism, right? But a patient should not conceive while she is on any of these anti-androgenic drugs, right? So, all these options are not the right one. The right option is option D, that is weight loss plus folic acid. She should try for spontaneous conception, but if it fails, then she should go to induction of ovulation. Right? Remember, take a take home message that the first line always is weight loss. After weight loss, then you try for ovulation induction with letrozole or clomiphene citrate. Metformin should be added only if your patient has insulin resistance. Clear? Okay. Coming to the next question. Next question was a pretty easy one. What is the most common cause of puberty menorrhagia? All of you know that the most common cause of puberty menorrhagia is anovulation. That's the most common cause. And second most common cause is a bleeding disorder. Again, I have attached a screenshot. Most common anovulation and second most common bleeding disorder. In a case of puberty menorrhagia, you don't need to do an ultrasound. Absolutely, it's not absolutely essential because we know that in most of the cases it is happening because of anovulation. Only if you are suspecting some other cause other than anovulation, then you should be going for ultrasound. Similarly, coagulation profile should be done only if you are suspecting a bleeding disorder, right? Then you should go for a coagulation profile. Now, quickly, I want you to revise with me. How do you manage a case of puberty menorrhagia? In patients of puberty menorrhagia, you divide them into two categories, whether the hemoglobin of the patient is more than 10 or it is less than 10. If patient's hemoglobin is less than 10, that means she is a case of severe bleeding. She's having severe bleeding. Now, in cases of severe bleeding, what you have to do is, because severe bleeding means that the endometrium would be very thin. Endometrium will be very thin, and this is what I have taught you in your videos also. So, endometrium is thin, and whenever endometrium is thin, that progesterone cannot act on endometrium which has not been primed by estrogen. This is a line which we all of us read so many times in our textbooks. This means that progesterone cannot act on a thin endometrium. right? Because thin endometrium means that just now estrogen has not done its work on endometrium. So in this case, I cannot start with progesterone. In this case, you have to start with estrogen and then you have to give progesterone. So whenever you are having severe bleeding, whenever patient has severe bleeding with thin endometrium, you have to see whether the vitals are stable or unstable. If vitals are stable, then you have to give high dose estrogen and progesterone pills, right? So in them, estradiol levels should be more than equal to 50 micrograms. That's a high dose pill, right? And if the vitals are unstable, then you have to give IV estrogen followed by maintenance therapy, which is going to be oral combined pill. This is if hemoglobin is less than 10. If hemoglobin is more than 10, in that case, if your patient is having mild bleeding, you simply have to reassure her and you have to give her IFA pills, right? And you may also give her NSAIDs. But if your patient is having moderate bleeding, then in that case, you have to see whether the patient is presently bleeding or presently she is not bleeding. If the girl is presently bleeding, see, for all AUBs, we have only 3 drugs which are there with us. You can use OCPs, you can use progesterone, or you can use tranexamic acid. The sequence is going to vary. Now, if your patient is presently bleeding and she's having moderate bleeding, in that case, I will prefer giving her OCP rather than giving her just progesterone. Why? Because the estrogen which is present in OCP is hemostatic, right? But if patient is presently not bleeding, then I can give her only progesterone. So everything depends upon the question which is asked. If you are getting moderate bleeding with moderate amount of puberty menorrhagia and patient is presently bleeding, your answer is going to be that I am going to give her oral combined pills. If patient is presently not bleeding, you are going to say I am going to give her progesterone only pills. If your patient is having severe bleeding, this means there is a thin endometrium, and this means that I just cannot give her only progesterone. Only progesterone will not work in this case because thin endometrium means estrogen has not acted on the endometrium, and so now progesterone will not work. So in this case, you have to first give estrogen followed by progesterone, or you have to give estrogen and progesterone together. That depends upon if the vitals of your patient are stable, you give high dose estrogen and progesterone pill. If vitals of your patient are not stable, then you give IV estrogen followed by progesterone. Clear? And that progesterone can be in the form of only progesterone or it can be in the form of oral combined pills, preferably oral combined pills. Right? Clear to all of you? So that is how you manage a case of puberty menorrhagia. Then comes a next question which came on vaginal discharge. A lady on OCP presents with white discharge that presents with no itching or foul smell. So no itching or foul smell are the keywords here. It stains her underwear yellow in color, and on examination discharge, normal lactobacilli were present. pH was acidic. What is the most probable diagnosis? Now you tell me, what are those conditions where you get no itching? Discharge with no itching. There are only 2 conditions where you get discharge with no itching. Number 1 is bacterial vaginosis and number 2 is the leukorrhea. Leukorrhea, that is physiological discharge, right? Now, how do you differentiate between them? In case of bacterial vaginosis, foul smell will be present, whereas in case of leukorrhea, there is no foul smell, number 1. Number 2, in case of bacterial vaginosis is an alteration in the genital flora, right? So, over here, lactobacilli will be decreased, but bacilli like Gardnerella, Mobilicus, all of them will be increased. Whereas, in case of physiological discharge, lactobacilli will be normal, right? You are going to get normal levels of lactobacilli. Now, your question is saying, number 1, the discharge is non-foul smelling. Number 2, lactobacilli are normal, which means it is pointing towards physiological discharge. So, increased normal vaginal discharge. Clear? In case of vaginal candidiasis, the main complaint of the patient is itching, right? Main complaint is itching. Patient comes to you with pruritus in case of vaginal candidiasis, and the discharge in that case is curdy white discharge or cottage cheese like discharge, right? So the answer over here is your increased vaginal discharge, and this again I have taught to you in gynae physio integration. In gynae physio integration, I have taught to you that leukorrhea or physiological discharge, it could be thin in the first half of the menstrual cycle under the effect of estrogen, or it could be thick in the second half of the menstrual cycle under the effect of progesterone. Then it has two characteristics. It is non-foul smelling. It is not itching. Right? It doesn't itch. Right? So the question, the answer over here was physiological discharge. Then comes your next question. Next question was also related to vaginal discharge, and this time they had asked, a 32-year-old female presents with grayish white discharge, which on gram stain of the discharge clue cells are seen, and it is, you all know that clue cells are seen in cases of your bacterial vaginosis. And what is a clue cell? A clue cell is a vaginal epithelial cell to which the bacteria are adhered. So it is epithelial cell covered by bacteria. That is, option C is correct. So over here in the video of vaginitis, I have made you draw a table where I have told you what are the clinical features, how do you diagnose bacterial vaginosis and all the other infections. So in this case, I have told you that the investigation of choice in all case of vaginitis is saline microscopy, and on saline microscopy, in case of bacterial vaginosis, you get clue cells. What are clue cells? Clue cells are vaginal epithelial cells to which the bacteria are adhered. So this is how a clue cell appears, that it is, it is a very dirty kind of a vaginal epithelial cell to which number of bacteria are adhered. That is how a clue cell looks like, and clue cell means that it is a case of bacterial vaginosis, right? Now, another thing which I want you to remember about bacterial vaginosis is Amsel's criteria. What is Amsel's criteria? If any of the three are present, then you say that bacterial vaginosis is there, and out of these four, any three should be present. Number one, you should get off-white or grey color discharge, and as in the question, they are saying it's a grey color discharge. Number two, pH of the discharge should be more than 4.5. Number three, clue cells should be present more than 20% of the entire epithelial cells. So out of all the epithelial cells, more than 20% should be clue cells. Number four, when you add 10% potassium hydroxide to the discharge, you should get a foul smell or a fishy odor, right? Now, management, how do you manage a bacterial vaginosis? The drug of choice for bacterial vaginosis is metronidazole, which you have to give 500 mg BD for 7 days, or you can give clindamycin 300 mg BD for 7 days. Please remember, bacterial vaginosis is not a sexually transmitted disease. That is why partner treatment is not done. The investigation of choice in case of any vaginitis, similarly for bacterial vaginosis, is saline microscopy. And for trichomonas and candidiasis, the gold standard was culture. For bacterial vaginosis, if clinically you cannot make a diagnosis, then in that case you will have to do gram staining, and you are going to do the Nugent score. And you are going to take out the Nugent score, right? Next question is, choose the incorrectly matched option. So in this case, they have given you prolapse surgeries, and they have asked you in which condition you do that surgery, right? So rectocele, what is the surgery for rectocele? It is posterior colporrhaphy. Uterine prolapse, vaginal hysterectomy. Vault prolapse, sacrospinous ligament suspension. Till here everything is correct. Cystocele, colposuspension. No. For cystocele, what is the surgery done? For cystocele, the surgery which is done is anterior colporrhaphy. Anterior colporrhaphy. Right? Where do you do colposuspension? Colposuspension, the name is Bursch colposuspension, and this is the gold standard surgery which is done in case of stress urinary incontinence. So I have made you write all these surgeries over here. For cystocele, anterior colporrhaphy. For urethrocoele, also anterior colporrhaphy. For enterocele, you do MEC-cal caldoplasty. That's the one which is most commonly being done. The others which are now not done and are outdated are Moskowitz repair and Halban's repair. Then for rectocele and lax perineum, you have posterior colpoperineography. So these are all the surgeries. Please remember that in case of vaginal prolapse, the surgery doesn't depend upon the age or parity of the female. But in case of uterine cervical prolapse, uterocervical prolapse, The surgery depends upon the age and the parity of the patient, right? Now, whenever you are doing anterior colporrhaphy and posterior perineorrhaphy together, that is called as pelvic floor repair, right? And whenever you are doing vaginal hysterectomy and pelvic floor repair, that is what is called as ward-Mayo's hysterectomy. So suppose your question says that there is a female who is 48 years of age, her family is complete and she has attained menopause, and she is having a third degree prolapse along with cystocele and a rectocele. What is the management of choice? What is the surgery of choice? Now, because she has a third degree prolapse, because she is menopausal female, I am going to do a vaginal hysterectomy for her uterocervical prolapse. For anterior colporrhaphy, for cystocele, I'm going to do anterior colporrhaphy, and for rectocele, I'm going to do posterior colporrhaphy. Now, anterior colporrhaphy and posterior colporrhaphy together are called as pelvic floor repair. And whenever you do vaginal hysterectomy with pelvic floor repair, the entire thing is called as ward-Mayo's hysterectomy. So remember this term, ward-Mayo's hysterectomy also. Okay. Now, surgeries for vault prolapse are very, very important. Surgeries for vault prolapse, you can do abdominal surgeries or vaginal surgery. The abdominal surgeries are difficult to perform. This surgery is difficult to perform, but it is the best surgery, and this is sacral colpopexy. Then comes vaginal surgery. In vaginal surgery, we have uterosacral suspension or sacrospinous fixation, right? Uterosacral suspension is prophylactic also, and it is therapeutic also. So next question, that is related to male infertility, and a very, very interesting question, and that is, fructose is absent in seminal fluid. Which of the following statement is true regarding this? Okay. Now, please understand that whenever you are doing semen analysis and you get a report of azoospermia, right? And they ask you what is the next step? The next step becomes that I am going to repeat semen analysis. And after how much time are you going to repeat semen analysis? In a month, right? In a month. So after 1 month, you are going to repeat semen analysis. Now, in repeat semen analysis, if azoospermia is confirmed, then what is the next step? Then the next step is you check FSH levels, right? Because if FSH levels are decreased, it means it is pre-testicular azoospermia. Right, that means the problem is in hypothalamus or problem is in pituitary. It could be Kalman syndrome, it could be thyroid problem, it could be increased prolactin levels, hyperprolactinemia. Then if FSH levels are increased, right? Now, if FSH levels are increased, that means it is a case of testicular azoospermia. So the problem is in the testes, right? That could be Klinefelter's syndrome, that could be mump orchitis, or that could be excessive heat exposure. And if FSH levels are normal, it means that hypothalamus, pituitary and testes are normal. Problem is in sperm pathway. That means it's a case of obstructive azoospermia. And once I know I am dealing with obstructive azoospermia, how do we proceed further? So, in your videos, I have told you how are you going to approach a case of obstructive azoospermia. Please understand, bachcho, that this over here is the sperm pathway. Sperms are produced in the testes, in the seminiferous tubules. From there, they are going to go into the epididymis, where they are going to attain maturity and motility. From there, they are going to come into the vas deferens. So then they are going to come into vas deferens. While they are passing down the vas deferens, seminal vesicle is going to pour its secretions, and then prostate is going to pour its secretions, and it via ejaculatory duct, then it will be ejaculated out. At the time of ejaculation, Bartholin glands is going to pour its secretions. So, semen, how is semen formed? So, major contribution to the semen, it comes from the fluid of seminal vesicles, then through prostate gland, and then at the time of ejaculation, bulbourethral glands, they give its secretions, right? Now, depending upon the semen report, with what is the volume of the semen and what is whether fructose is present in semen or not, I can come to know if the block is happening above the level of seminal vesicles or if the block is happening below the level of seminal vesicles. Right, because it is the seminal vesicles which contributes major volume to the semen, and it is seminal vesicle fluid which contains fructose. So suppose if I am getting that the block is above the level of seminal vesicles. The block is over here above the level of seminal vesicles. I am marking it with green color, right? So block is above the level of seminal vesicle means that the block is either in epididymis or it is there in the vas deferens, right? Now, if block is above the level of seminal vesicle, when this male is going to ejaculate, then sperms will not be able to come down. But when this male is going to ejaculate, semen is going to be present, and that semen will have contribution from seminal vesicles. It will have contribution from prostate and from bulbourethral glands. That means semen is going to have a normal volume and fructose will be present. Right, so whenever you have azoospermia, obstructive azoospermia, where LH, FSH, testosterone are levels are normal, check the volume of semen and check whether fructose is present or not. If volume of semen is good and fructose is present, it means seminal vesicle has given its contribution to the semen, and that means obstruction is either in epididymis or in vas deferens. And in order to know where is the exact site of obstruction, you have to do a scrotal ultrasound. On the other hand, suppose if block is happening, now I am erasing this, and suppose the block is happening below the level of seminal vesicles, right? Now, if the block is happening below the level of seminal vesicles, when this male is going to ejaculate, in the semen there will be prostatic fluid and there will be fluid from bulbourethral gland, but there won't be any sperm and there won't be any seminal vesicle fluid. So, this means that semen is going to be less in volume and semen is going to have absent fructose. Similar situation is going to arise if there is a male in whom there is bilateral absence of seminal vesicle. And when does this happen? This happens in case of cystic fibrosis. In a patient of cystic fibrosis, there is congenital bilateral absence of vas deferens and congenital bilateral absence of seminal vesicles. So, whenever semen is low in volume and there is decreased fructose, it means semen has come from prostate and bulbourethral gland. That means seminal vesicle has not poured its secretion, and this is seen in case of congenital bilateral absence of seminal vesicles, which is seen in case of cystic fibrosis, or it means there is an obstruction to the ejaculatory duct. Now, in order to know what is the exact cause, I am going to look for CFTR gene mutation, because CFTR gene mutation is seen in cases of cystic fibrosis. And in order to know whether the problem is in ejaculatory duct, where is the problem in ejaculatory duct, I am going to do a transrectal ultrasound, right? So, your question is saying, so all this I have taught to you in marrow videos as well. So, they are saying fructose is absent in seminal fluid. Which of the following statements is true? Congenital bilateral absence of seminal vesicles, obstruction to ejaculatory duct, both. Both of them are correct. Clear? Okay. Coming to the next question, which is, which of the following is a true association with HRT? Now, HRT, when we say this HRT basically means estrogen HRT. But we all know that if we are giving only estrogen as an HRT, and if uterus is present in a female, that leads to an increased risk of endometrial cancer, right? And that also leads, because of the estrogen component, there is increased risk of thromboembolism. Now, whenever you are giving HRT, whether it is estrogen only HRT or estrogen plus progesterone HRT, in both these cases, there will be decreased incidences of hot flushes, and that is why the first line management for hot flushes is HRT, and the only indication for giving HRT these days is hot flushes, right? Number two, whenever you give HRT, it decreases the incidence of colorectal cancer. But if you are giving only estrogen HRT, that increases the incidence of endometrial cancer. There are increased chances of thrombosis and ovarian cancer plus minus. On the other hand, when I am giving estrogen plus progesterone HRT to females in whom uterus are present so that they don't have endometrial cancer, the advantage is that yes, hot flushes will decrease, colorectal cancer will decrease, and there will be decreased endometrial cancer. But the problem is that still patient will have high chances of thrombosis, and still there will be plus minus chances of ovarian cancer, and one more cancer risk is increased, and that is breast cancer. Whenever you are giving estrogen plus progesterone HRT, the progesterone component in it is associated with increased chances of breast cancer, right? So let us see which of the following statement is true. It decreases the risk of colon cancer. Yes. There is decreased risk of breast cancer. No. Right? HRT could mean either estrogen HRT or estrogen plus progesterone HRT, and whenever progesterone is added, it increases the risk of breast cancer and it doesn't decrease the risk of breast cancer. Decreased risk of endometrial cancer. Decreased risk of endometrial cancer is seen only with estrogen and progesterone HRT, not with estrogen HRT. Right? And since they haven't specified which type of HRT, so I'm taking this statement also as incorrect. Increases the risk of osteoporosis? No, it doesn't increase the risk of osteoporosis. Because estrogen is present, it will decrease the risk of osteoporosis. Right? So the answer over here is decreased risk of colon cancer, which is the true statement. Which of the following drugs is not given in endometriosis? So suppose even if you don't know anything about endometriosis, all of you know that endometriosis is an estrogen dependent condition. If it is an estrogen dependent condition, how can you give her only estrogen, estradiol? If instead of estradiol, estrogen plus progesterone in the form of OCP would have been given, that was right. But your first option is estradiol. How can you give estradiol? Right? So this is absolutely incorrect. Now, in marrow videos, I've told you there are certain conditions, there are certain things which are true for all hyperestrogenic conditions. That those all hyperestrogenic conditions are fibroid, endometriosis. So the drugs which are used for management of fibroid and endometriosis, they are more or less the same because our aim is to decrease the levels of estrogen. So how can you decrease the levels of estrogen? Number one, by giving progesterone. Why? Because if we look at progesterone, progesterone down regulates estrogen receptors. If we look at estrogen, estrogen up regulates progesterone receptors. Because progesterone down regulates estrogen receptors, so whenever you are giving progesterone, it will down regulate the estrogen receptors, and because it will down regulate estrogen receptors, ultimately there is going to be endometrial thinning. This is the reason why in all hyperestrogenic conditions, you give progesterone. This progesterone can be in the form of oral progesterone like medroxyprogesterone acetate, or it can be in the form of IUCD Mirena. Now, the oral progesterone which you are giving, you can give it continuously, right? Or you may give it cyclically for 10 to 12 days, right? So, yes, medroxyprogesterone acetate is being used. Then comes over here, it was not leuprolide, it was letrozole. Okay, that is number one drug which is used in all hyperestrogenic conditions. Number two, you can use continuous GnRH. Continuous GnRH can be used in cases of hyperestrogenic conditions because when you use continuous GnRH, it decreases LH, FSH and estrogen. Number three, you can use GnRH antags, right? Number four, you can use a drug that is an aromatase inhibitor which is going to decrease the conversion of androgens into estrogen. Androgens are converted into estrogens in adipose tissue with the help of enzyme aromatase. So, aromatase inhibitor, letrozole can be used for managing hyperestrogenic conditions. Then number five, you can use a drug danazole. But although I can use danazole in hyperestrogenic conditions, but danazole has a big problem that it leads to androgenic side effects. It leads to androgenic side effects like hirsutism. So you should not be using danazole in a young female. So these are all the drugs which can be used in all hyperestrogenic conditions like endometriosis and fibroid, and all these five drugs should be on your fingertips, right? Now, so letrozole can be used. What about cabergoline? See, cabergoline, the recent data says that when you are treating a female with cabergoline, it suppresses cell proliferation and vascular endothelial growth factor mediated angiogenesis, and that is why it promotes the regression of endometriotic lesions. So theoretically, cabergoline can be used in patients of endometriosis because it is decreasing VEGF associated angiogenesis. But practically, we don't use cabergoline for this purpose. But nevertheless, if I had to choose one drug which is not given in endometriosis, the answer remains estrogen. You cannot give estrogen as it is to a patient of endometriosis. In a patient of endometriosis, apart from these drugs, you may give OCPs. Why? Because one of the theories for endometriosis is that endometriosis happens because of retrograde menstruation, right? So, when you are giving OCPs, what will the OCPs do? OCPs, and you have to give OCPs continuously. You have to give OCPs continuously to a patient of endometriosis for 90 days. For 90 days, when you are giving OCPs, patient will not menstruate. So because she will not menstruate, retrograde menstruation will not happen and new implants will not be formed. Right? So you can use OCP in a patient of endometriosis. Rather, for a very long time, OCPs were the first line management of endometriosis. Right? But then Akele you cannot, singly you cannot use estrogen in a patient of endometriosis. Clear? Coming to the next question, 28 weeks of gestation. At 28 weeks of gestation, a lady presents with fever, acute pain in abdomen and mild leukocytosis. What is the most probable diagnosis? So I'm sure all of you know that this is a case of red degeneration. Points which are going in favor of red degeneration is patient is presenting to you at 28 weeks of gestation, which is in the second half of pregnancy, number one. Patient has fever, acute pain in abdomen and she has mild leukocytosis. If you remember, I have told you in a patient of red degeneration occurs in second half of pregnancy. Patient complains of pain in abdomen, nausea, vomiting. It is an aseptic condition which happens due to thrombosis in the blood vessels supplying the fibroid. But still you may get increased WBC or increased ESR. Why? Because of reactionary changes. Right? And management of red degeneration is always conservative. You don't have to give any antibiotics. You don't have to terminate pregnancy and no myomectomy. So you don't have to do any of these things whenever you are managing red degeneration of fibroid. And the question was pretty simple, that it is a case of red degeneration of the fibroid. Right? Next question, which of the following is not perinatally transmitted? Now, here is the main thing. They are asking about perinatal transmission, but you please understand that there is a lot of difference between intrauterine transmission, prenatal or perinatal transmission and postnatal transmission. So prenatal or intrauterine, then perinatal and then postnatal. Perinatal means infection is being transferred. Vertical transmission is happening at or around the time of labor, right? So when we are talking about infections which are transmitted at or around the time of labor, that is perinatal infection, and there are certain infections which are not transmitted perinatally. For example, syphilis. Syphilis is not transmitted perinatally. Rubella is not transmitted perinatally. Plasmodium falciparum, that is malaria, is not transmitted. Trypanosoma, E. coli, these are the infections. Toxoplasma and parvovirus, these are infections which are not transmitted perinatally. Do not confuse perinatal infection with antenatal infection, right? On the other hand, there are certain infections which have maximum transmission at the time of labor. What are such infections? Such infections are hepatitis B. Hepatitis B is maximally transmitted at perinatally. Then group B streptococci, then chickenpox, herpes simplex virus, chlamydia and cytomegalovirus. These hepatitis virus, all these infections are maximally transmitted perinatally. As far as rubella is concerned, which was given in your options, rubella transmission happens maximum in the first 11 weeks of pregnancy. Then between 11 to 20 weeks of pregnancy, and beyond 20 weeks, rubella infection ka vertical transmission is very less. And there is no perinatal transmission or extremely less perinatal transmission of rubella. right? So the answer to this question is rubella. Cytomegalovirus, maximum transmission happens perinatally. HSV, maximum transmission happens perinatally. Hepatitis B, maximum transmission happens perinatally. Now, I want you to remember all those organisms or all those infections which are not perinatally transmitted, and for that you are going to remember the mnemonic call PQRST, where C stands for E. coli, P stands for parvovirus B19 infection, Q is nothing, R stands for rubella, S stands for syphilis, T stands for toxoplasma, and trypanosoma. So here is your list of infections which are not transmitted perinatally, right? So this brings us to the end of discussion. So we have discussed all the questions which were asked in your INI-CET May 2023. And now as I'm concluding, we also know the date for your next INI-CET, which is November 5th. So just in case you are unable to get through May INI-CET or the desired rank you haven't obtained, now how are you going to strategize your and focus for your 5th November INI-CET? Now, you have a lot of time in your hands starting from June also. Suppose I'm not even counting mid of May, I'm counting it straight away from the 1st of June. From 1st of June to 5th of November, you have plenty of time in your hands, Pacho. Now, how you are going to prepare now? Since you have given INI-CET, since you've given NEET, right? So you know what are your weak subjects and what are your strong subjects. Now, starting from 1st of June, you should first focus on your weak subjects, and because we are targeting the November INI-CET, I would prefer that you focus on your first and second year subject. This time, you are not going to do just previous year topics. You are not just going to do previous year questions. Starting from 1st of June and going up till 15th of August, you are going to do a complete reading of all your subjects. Now, how do you do that complete reading? No matter what source, whatever is your primary source of information, you are going to read that register or that notes from first page to last page, right? Because this is the only time when you are going to do that. So please take your time, read whatever notes you have made till now. Starting from 1st of June and going up till 15th of August, you are going to read all subject notes from first page to last subject, giving main focus on first or second year subjects, because just in case those are the subjects where you lacked when you gave May INI-CET, or any other subject which you feel you are lacking, that should be your first subject to pick up, right? Now, during this time, give your GTs after every 2 weeks. Now, from 15th of August, going from 15th of August to 15th of October, now you are going to do your second reading. In second reading, if in the first reading you were focusing mainly on first and second year subjects, now in second reading you should focus mainly on clinical subjects, because ultimately you have to give NEET as well, and in NEET there is a lot of weightage of clinical subjects. Right, so starting from 15th August to 15th October, do your second reading. In second reading, now the registers which you have in your hand, now start marking those registers that these are the points which I keep on forgetting. This should be done in your second reading, right? And now start giving GTs after every 10 days. Then comes your third reading. This third reading, which is going to start from 15th October and it is going to go up till your INI-CET exam. In this third reading, now is the time when you are going to do only and only the revision notes of whatever source you are following and those highlighted areas in your registers which you have marked. And now you are going to lay a lot of stress on previous year topics. Take up previous year questions, just don't solve the PYQs. Look at those topics, read those topics, write those important points. If any point is missing in your revision notes, write those points in your revision notes. And this is what you are going to do from 15th October till your exam. Right? So and now, yes, if you are going to give GT after every week, you cannot clear your exam without practicing MCQs. That goes without saying. So you have to practice MCQs, because if you see the trend, what is, day by day, the trend is moving towards clinical questions, trend is moving towards where you can rule out two options, but you get stuck between two options. And that happens because either you've not practiced well or your concepts are not clear. Right? So now in these 6 months from May to November, focus on these areas, practice MCQs, try to build up your concepts and simultaneously keep on revising. So I hope this proves beneficial to all of you. Take care. Bye-bye, bacho.